Well, good afternoon, everyone. Welcome to Cardiac College Online for today, June the 23rd. My name is Paul O. I'm the medical director in the cardiac rehab program, and it's my pleasure and privilege to be back with you. Let me just do a quick date correction. Of course, it's only Monday, June the 22nd. This is the Monday series where we are living and thriving with heart disease together, and I'm glad to be able to join you. Today's session is titled, What is a Heart Attack? We promised this to you a couple of weeks ago when we were together, and we thought that given that many of us might have been through a heart attack experience, and some of us may be trying to avoid this in the first place, it might be worthwhile having a detailed conversation about what are some of the elements of the heart attack. What does it represent from a internal physiology basis and what's going on in our arteries? How might we recognize this from the perspective of symptoms? How might this be different for men and women? And then let's just talk about some of the other diagnostic characteristics, and then wrap up with a couple of approaches to treatment, which may seem familiar more than you might want for some of the folks in the audience. This is me, and I'm glad to chat with you. One day we'll all get to be active together again. A reminder, and you're very familiar with this now from having joined so many of these sessions, that the focus for these get-togethers are for education only, and we would encourage you to chat with your own healthcare provider if you need some specific advice about your situation. We do ask you to use the Q&A feature of the Zoom platform to ask your questions, though, and I'll look forward to addressing some of those as we move along through the chat. We'll certainly endeavor to address all of your questions by the time we wrap this session up today. You'll recall that a few weeks ago, we introduced the different systems of the heart. So here's a little bit of a throwback to represent that the physiology or the anatomy of the heart includes all those different chambers, the atria and the ventricle, the valves that connect the chambers together. We've talked last time about the electrical system that's inherent in the heart. And then to continue out the analogy of your heart being a home with walls and doors and windows and electrical system, etc. Today, we want to talk about the blood vessels and the circulation around the heart. So it's the blood supply or plumbing that we really want to talk about. And the manifestation of plumbing problems in the heart is disease in the coronary arteries. Over a long-term view, and we're going to dive into each of these little circles in a second, that we have, many of us are living with coronary artery disease, and in fact, much of the population will develop coronary artery disease at some point if we give enough time. And the reason for this is that over a period of decades, we see that from a very clean, open blood vessel when we are in our youth, that over time we start to develop little bits of plaque and atherosclerosis that go up over decades of life. When this significantly compromises the opening of this blood vessel, like over 70% narrowing, then we might start to feel symptoms like chest pain or angina. But we really get quite concerned if this blockage suddenly turns into a complete occlusion and blocks off blood flow completely. That is what represents the heart attack. I thought we would spend just a few minutes walking through this in a little bit more detail. So we've said that we've got a lot of blood vessels that actually sit on the surface of the heart for large part. So they're called epicardial vessels, epi meaning outside, cardium means heart, the epicardial vessels. And we've got some that go around the left side of the heart and some around the right side of the heart. The major branches include the right coronary artery on the right side and the left main artery that comes off the left side that divides into two major branches. One is called the left circumflex, meaning that it wraps around the side, as well as the left anterior descending artery. So that's the left, the front, and going from top to bottom, left anterior descending artery. And you'll see that this cartoon shows that they've got little smaller tributaries that feed blood supply ultimately into the muscle of the heart. And the purpose of these coronary arteries is to supply blood and oxygen to the muscles of the heart so that it can do all of its wonderful pumping function. The concerns that we have are when these blood vessels change. And if you'd like to see a version of these animations kind of in more detail, I'd invite you to go to the American Heart Association website. They've got a great series of information for patients under the Watch, Learn, and Live library. And here, if we think we're looking at this artery on the surface of the heart that's really been blown up here, this is, again, what an artery looks like when we are in our teenage years. The vessels are lovely and smooth and clear, and you can see that there is really no restriction to the blood flow. The blood vessel is made up of three major layers. The kind of the grayish lining is called the intima, just like intimate apparel. This is the inside stuff of the artery. It's meant to be smooth, and blood just flows freely past that. The media is this muscular wall around the artery. And remember that arteries squeeze and relax, and the muscles are located in the media. And then there's supporting structures that hold our vessels in place. This is called the adventitia. The problems that we experience over time occur between the intima and the media of our arteries. And you can see here in this first stage of the cartoon, what's being demonstrated is that yellow buildup, fatty deposits called plaque that can build up in the coronary artery walls. And this process, unfortunately, may start off very early in life, like in our 20s. And there's these famous observations of young soldiers who unfortunately met a bad outcome during the Vietnam Wars. And when their hearts were examined at post-mortem examination, and they looked into the heart vessels, they found that there was a little bit of fatty buildup, even in very young, otherwise healthy people. These are called fatty streaks, or fatty deposits, or early plaques. So these clearly show that the process of developing blockages in our arteries takes decades of life. After some time of building up these plaques, and this involves cholesterol, for instance, from our diet and from our liver, we've talked about that concept before, circulating around our bodies and depositing into areas like the artery walls. The cholesterol deposits undergoing change through cells that live inside these walls and being transformed into oxidized or fatty plaques that are inside here. And when we get enough of that activity built up, both in size and composition, these plaques may become vulnerable or unstable. It's like the surface of a volcano lava layer that looks like, well, maybe there's some solid stuff, but if you just poke at it, you see that there's this red, angry lava that's just underneath there getting ready to rupture. And that's when we get quite concerned about vulnerable plaques. On the other hand, sometimes these plaques can actually cool down somewhat. And so for some people, if they've been living with these plaques for a long time and have been able to get risk factors under control, like blood pressure and cholesterol and diabetes, and have been able to stop smoking, well, sometimes we still may have some plaque buildups, but if there's a thick fibrous shell that builds up around there, this plaque may actually become quite stable and not so much prone to rupture. It's the other kind that we get worried about. And sometimes those vulnerable plaques, if they are unstable, may rupture. And this is just like the volcano that takes off after a number of years of being quiet or dormant. It is possible to destabilize one of these plaques. And sometimes that occurs in response to stresses, sometimes in response to physical exertion, sometimes in response to noxious stimuli like smoking. And that's why under any of these kinds of stressful conditions, we're concerned that we might trigger a heart attack. At other times, there may not be a specific acute stimulus that causes these things to rupture, but it just may be the nature of the underlying plaque itself that leads to this kind of event. When the plaque ruptures and we expose that plaque underneath to all of those cells that are floating around in the bloodstream, we talked before about how this can actually lead to the next event, like thrombosis. Remember the life of those platelets? We talked about the trillions of platelets that float around in our bloodstream. When the platelet sees that something's been ruptured, it thinks that there's been some sort of injury to the body, and it recognizes that injury to the plaque as something that must be blocked up. It's trying to seal the hole, so to speak. So this process of thrombosis starts internally by our own body defenses, not recognizing that thrombosis inside of a coronary artery is probably not a good idea. And if that blood clot gets larger, then there's progressive restriction of blood flow down that artery. And as the clot gets even bigger, we lose more blood flow up until the point where that thrombus grows all the way across and blood flow is completely blocked off. So now, no blood flow going, no oxygen traveling, and anything downstream from the blockage gets into a lot of trouble. It's like that terrible accident that occurs on the highway, or if someone plugs up the local creek bed, then there is no flow that happens from there. And when that blockage occurs in that segment of the artery, then everything downstream from there, including the heart muscle, gets damaged because it does not get its oxygen supply anymore. Unfortunately, the muscle becomes damaged. It may even die off. And when that muscle dies off, that is called a myocardial infarction. This is manifest often by pain. We're going to talk about that. It is manifest by irritation in this whole area. It could be electrical irritation. It could be irritation that the pump just doesn't move very well anymore. And we can also measure this using some diagnostic tools. Like if we were taking pictures of the heart, you would see that that section of the heart that's been damaged just won't move anymore if we're doing an echo picture or doing an angiogram watching that heart move, or doing a nuclear picture of that section. It's not getting any blood flow. If we are also doing some blood tests, we'll be able to pick out that this damaged muscle releases substance into the blood that can actually be measured. So that's a sign of heart damage. And then finally, if we're doing electrocardiogram tracings, then the electrical flow through this damaged muscle section just doesn't work very well anymore. So we're going to walk through all of those elements in the next series of slides. So the signs and symptoms of coronary artery disease or heart attack from the loss of blood flow and damaging heart muscle can be felt in these ways. And this is an infographic from the Heart and Stroke Foundation of Canada that describes the usual kinds of symptoms that we often associate with heart attacks. Now, this is kind of the description of populations in general, but each person develops his or her own kind of fingerprint on what your experiences might have been. And it would be interesting perhaps to share if we were live together in person, then we could kind of go around the room and talk about who felt what. But most often we will ask you about some sort of discomfort in the chest. And we might describe it as discomfort as opposed to pain, because some people might just feel it as a pressure or a squeezing, or just might feel unusual and full. Some people have said it kind of burns or it's heavy. Occasionally someone says, oh, this is classic. I'm feeling like the elephant is sitting on my chest. But most often people will use their own other kinds of words. Because this is such a stressful situation to have the blockage of the blood flow and loss of oxygen to our muscles, our bodies may tell us, look, I am so stressed out. I'm going to start sweating, which is a sympathetic activity that happens. And interestingly, some people just sweat and nothing else going on. Intense sweat with no good reason. I got to think the heart may be involved with that. Some people may not feel something in their chest. They may feel it somewhere else, like in the neck or the jaw or the shoulder or the arm or into the back. And the explanation for this is that the heart itself is not so smart at telling you exactly where you got hurt. Whereas things like the hand that has a whole bunch of nerves representing it up to the brain, when you hit your thumb, for instance, with a hammer, your brain tells you exactly what part of your body has been hurt. There's no mistaking the thumb for your index finger, for instance. Your brain knows exactly where it gets hurt. But with the heart, anything in the middle of the chest is not well represented in the brain, at least from a pain perspective. So when the heart feels like it's hurting, the brain may think, well, it's somewhere around there, but it could be your arm, it could be your shoulder, it could be your jaw, or it could be your heart. So the localization is imperfect with respect to pain from the heart region and where the brain thinks it might be. And of course, some people might feel both, that it might be in the chest and the back, or the chest and the shoulder, or the neck or the jaw. So bear that in mind. Again, what's interesting is that each person may develop his or her own unique characteristic and pattern. And that's the thing that we're going to watch for. And after you've recovered from a heart attack or a heart experience, we're going to ask you, are you getting that same kind of pain, or is this something different? This is particularly relevant for people that might have had an angioplasty or surgery, where you may develop new aches and pains that are really unrelated to the heart, but which in the first go might give us some concern. If we can differentiate one from another and allow us to become more comfortable with that, then we focus, are you ever getting your heart attack symptoms versus something else? If it's something else, please carry on with your day. If it's your heart attack things, then get yourself some medical attention. Okay, some people also feel nausea or vomiting as their predominant symptom with heart attack. And the reason for that is that there are some other nerves that come around the heart that share localization in the brain with our nausea centers. And in particular, heart attacks that might affect the lower parts of our heart are classically associated with feelings of nausea and vomiting and slowed heart rates. So that's something that we need to pay attention to. Is it food poisoning? Is there really a good reason for you to have food poisoning? If not, then let's be concerned that it might be your heart that's acting up. The fifth thing here is that some people may not perceive much in the way of chest discomfort, but they may feel more in the way of shortness of breath. If the heart is made compromised, if it's dysfunctional, if it's not beating as well as it might otherwise, then there's the possibility that we might feel some pressure or even fluid backup into our lungs, and that might give us a sensation of shortness of breath. Sometimes if the heart isn't getting enough blood flow, then it may feel pain, but sometimes it just feels instead shortness of breath, and we call that an angina equivalent. And then finally, one characteristic symptom is lightheadedness. And that may arise from, again, the heart not pumping as well as it might be, not getting enough blood flow up to the brain. And our sense from our brain activity is, look, I'm not getting enough blood flow, blood pressure. I'm going to make myself a little bit dizzy and tell you that I need some help here. Thank you very much. These are general symptoms. For men, this picture describes the classical description of heart attack in men. And there was even a physician from many years ago named Dr. Levine who characterized this thing called a Levine sign, where if you're clutching at your chest, especially with a fist, then that's a sign that the heart is compromised either with angina or a heart attack. So the classical thing is chest pain in the middle or the left side that goes to your jaw or your arm, associated with some nausea, associated with shortness of breath. If you've got all of them, that's a pretty high likelihood that you've got a heart attack if you're a man or even a woman. But women may also feel some other things. In addition to the chest discomfort, you may have some other things, but women more often don't have that chest pain per se. It may be felt like something else, again, something other than the word pain. And it may be higher up, like in the back, or maybe lower down in the belly, or the upper part of the abdomen. Yeah, women may feel more often the desire to faint in the setting of a heart attack, or a feeling of indigestion, or just really profound tiredness or fatigue, even in the days leading up to the heart attack. So being aware of some of these unusual characteristics in women, which are actually not that unusual. It is just that is the fingerprint or the characteristic for women. The textbooks for the last number of decades have been written for men. But now we're recognizing, of course, that people present individually, and that women in particular may have their own characteristics. And this other infographic from the American Heart Association describes this kind of contrast between men and women. Some things are the same, like nausea, vomiting, jaw, neck or back discomfort, as well as some chest pain, but women less often have that chest discomfort. Shortness of breath may be a feature for both, but be aware, women in particular, pain or pressure in the lower chest or upper abdomen, the fainting, the indigestion, and the fatigue. Okay, so that's number one. So if we're in doubt and you're in the hospital, some of you may have had this experience, and in fact, most of you have probably had this experience if you are joining us on this web conference today. Remember, we said that if the heart muscle gets damaged and those cells actually die off, when they burst apart or get leaky at least, then they may release some substances into the bloodstream that can be picked up. And this, the current specific test that we use these days is called troponin. Troponins are a group of proteins that are part of the muscle cells themselves, the muscle fibers. And ordinarily, troponins are active, and they help muscles contract and relax, contract and relax. And that should look like a heartbeat. So that's where troponins sit. But if these muscles get damaged, muscle fibers get damaged because they've lost their blood flow, then a few things may leak into the bloodstream, including troponin. Normally, your heart cells are nice and intact and not damaged. So normally, you don't have troponin floating around in the bloodstream, except in very tiny amounts, because there is some turnover of cells. When there's damage to the heart muscle cells, troponin gets released into the blood. And if you damage a whole bunch of heart cells, then you'll get a larger amount of troponin. Usually it takes a few hours after the heart gets injured before the troponin values will go up. So if you present to the hospital right away and they take that first blood test, we're all going to expect that it'll actually come in pretty normal. But after a few hours, the telltale sign of a heart attack is that the troponin has gone up. Once it gets up, that it'll stay there for 10 days or more, until it gets cleared out of the blood vessel system or the blood system again. So it is a good early sign, but it doesn't necessarily tell you a few days down the road. You know, but for some people, it might be an interesting clue, right? So if you told us, look, I was away on the weekend and I had some unusual indigestion. It was really out of character, but we were out camping and I didn't want to come back to the hospital. Today I've come to the hospital and that event happened 2 or 3 days ago. If we measure a troponin in you and the level's high, then we could say, well, you know what? That episode of indigestion that you thought you had, well, that might have actually been a heart attack of sorts. That's the value of troponin to confirm what's going on in our hearts. The electrocardiogram is another valuable tool for us that can tell us what's going on from the electrical perspective of the heart. And you'll remember from our electrocardiogram and rhythm session that we had a couple weeks ago, that the electrocardiogram is like a snapshot, a camera shot of the electrical activity of the heart. And it's taken from 12 different angles, from the right, from the left, from the top, from the bottom, and from different angles. And there's a characteristic wave pattern in the electrocardiogram that is shown on this slide, that we characterize each of those little waves by these letter versions. And again, for mysterious reasons, it starts with a P and then goes to a Q, R, S, and T. And this nice regular pattern represents what normal electrical impulses do as electricity travels from the top of the heart down to the bottom of the heart through those cables. I want us to pay attention in particular to here. In this flat segment between the S and the T wave, and quite appropriately, that is called the ST segment. When the heart muscle gets damaged because we've lost blood flow, this ST segment, instead of being in a perfect line with everything else, starts to go a kilter. And in fact, what we're watching for is that ST segment to rise up. ST segment elevation is the abnormality that we're going to watch for as one of the very characteristic signs of a heart attack. So this normal electrocardiogram tracing is shown here, P, QRS, T, and that ST segment is in line with everything else. Here, we show you an electrocardiogram tracing from somebody who is having a heart attack. And everywhere there's a red arrow, it shows that the ST segment is way out, up and out from where it should be. This is the P, Q, R. The S wave should be way down here, but actually stops here and goes right into the T. This ST segment is several boxes higher than it should be. And if I ever saw an electrocardiogram like that in somebody who's lying on a stretcher in front of me with chest or back or shoulder or abdominal discomfort, who's sweaty and feeling faint, this is what a heart attack looks like from the electrocardiogram perspective. And from the 12-lead electrocardiogram from a heart attack, if I look at all the different camera angles and I see that there are abnormalities in this camera angle called V2 and V3 and V4 and V5, well, all of these leads go across the front of the chest. And this tells me that there's abnormalities all across the front of the chest. The front of the heart has been compromised in this way. And I'm going to bet that one of the blood vessels that's the front of my heart has been severely compromised. And this is the characteristic electrocardiogram abnormality from that. The other things that I can watch for in the setting of a heart attack, and again, we did talk about this last time, that if the heart muscle gets damaged or injured, it becomes quite irritable, and it might start firing off these wide, strange-looking beats called ventricular early or ventricular premature beats. Now, single ones are not so worrisome, but they are a sign that the heart's not so happy underneath there. When we get concerned, or when you string together a whole bunch of these abnormal beats, and this is called ventricular, and this is going very fast, tachycardia. We remember these terms before. This is the thing that we're watching for in the setting of a heart attack. And this is the reason that we would keep you in hospital for a few days at least on the heart monitor, watching for rhythms like this that require immediate treatment, like with a shock and or some medications to try to calm down the heart electrical activity until things heal up better. Okay, so I hope that that's clear, and maybe there'll be a couple of questions that we can address in a couple of minutes. All right, so that's the heart attack, loss of blood flow, looking at symptoms, looking at the blood tests such as troponin, and looking at the electrocardiogram. So what can we do about this? The preferred procedure, if you are experiencing a heart attack right now, is this thing called angioplasty and stenting, or the more general term for this is called a percutaneous, meaning going through the skin, under the skin into a blood vessel. Coronary, meaning let's get into one of these coronary blood vessels and do an intervention. PCI, percutaneous coronary intervention, PCI, or the descriptive terms are angioplasty and stenting. So you'll see here that if a catheter is placed down this blood vessel, this is the area of blockage, which would be the right kind of blood vessel for the one we were just talking about that would involve the entire front of the heart. Then we'll find where that blockage is. This has a wire and a balloon associated with it and a stent that is collapsed down. If you open up the balloon, then it stretches that plaque against the wall, and then you can leave behind this piece of metal stenting once the balloon and wire are withdrawn. So now this vessel is nice and open. And percutaneous coronary interventions, or primary PCI, is the preferred approach to treatment of one of these heart attacks. And if you're in the big centers like in Toronto or surrounding neighborhoods like Mississauga, Scarborough, Richmond Hill, Newmarket, etc., then this is going to be the procedure that you will receive if you show up to the hospital with a heart attack. And you know, the development of these procedures and the ability to get people treated within tens of minutes has been very exciting and an amazing advance to rescue people from heart attacks before there's a lot of damage done to these blood vessels. Now, if you're in a center, though, where it's very difficult to get to this angiogram room and have the balloon and the stenting put together, like if you're at the cottage far away from a medical center and transport was going to be difficult, then the before I get there, this shows us what an angioplasty and stenting might look like from the perspective of coronary angiogram. Now, this panel on the left-hand part demonstrates before, and this is after. And this is taken from the right side of the blood vessel, right coronary artery, where you'll see that most of this blood vessel is nice and large, except for right here at the tip of the arrow where it's pinched in together. That's where a plaque has formed and maybe even ruptured and has narrowed it down very tightly. And here, after the balloon and stenting has happened, you can see that that vessel is really nice and big, and the blood flow looks like it's running down this blood vessel very, very nicely. So that would be an excellent outcome from the angiogram, from the angioplasty, and from the stenting, and hopefully has rescued this individual and prevented much damage from the heart attack. Okay, so what I was getting to was that sometimes we may not have access to the cardiac cath lab, and we may not have access to angioplasty and stenting, but there is another approach to treating what's going on here. So if we imagine that there might be this clot of blood that's sitting inside a coronary blood vessel, then we can go back in time somewhat and think about these clot busting kinds of medications. We called them thrombolytics, meaning thrombo meaning clot, and lytic meaning breakdown, or fibrinolytic. Fibrin is this kind of meshy spider web that holds a clot together. So all of these terms might be used interchangeably: fibrinolytic, thrombolytic, or clot buster. And in the time that goes back about 20 years ago, clot busters were the first amazing advance to treat heart attacks. Nowadays, especially in the big centers, as we say, that more people are going to go directly to the angiogram room and try to get this clot actually just opened up entirely. But occasionally we still might rely on intravenous medications such as these ones: alteplase, reteplase, tenecteplase, streptokinase. Any one of these could be used to try to dissolve this clot and restore blood flow. And once you restore blood flow, whether it's from using these medicines or from an angioplasty and stent, then we'll often give medications like aspirin. We learned all about aspirin, and blood thinners like heparin that can be injected intravenously or under the skin to prevent more of these blood clots from forming. So that's the exciting part about treating heart attacks and rescuing us from these bad sort of events. This all, of course, sets us up for the next step, which is let's get ready and participate in rehab and get the vessels as healthy as possible for the rest of our lives. So that brings us to the end of what is a heart attack and what you can do about it. Let me jump into a couple of questions here. And number one, if you experience shortness of breath and you feel it's necessary to use your nitrous spray once or twice, but not 3 times, where you would have to call 911, should that be a concern that needs to be followed up with your cardiologist? So that's an excellent question. After having had one of these heart events, or an angiogram or angioplasty or even a surgery, then we may go home with that nitroglycerin spray. And the advice that you'll usually receive from a cardiologist is to carry it around. And one of the sessions that we do together in rehab is to think about how you might use that. Like, make sure you sit before you take the spray, just in case your blood pressure drops and you get busy. Your specific question is, if you use your spray and the pain goes away, wonderful, after 1 or 2. But if this is not your usual character, then that would be worth highlighting to your cardiologist. Like, if you've been very good for weeks or months, and then this is a brand new discomfort that you've experienced, then the bit of concern that we're going to have is something going on in that blood vessel. If you had an angioplasty and a stent, just making sure that there might not be anything going on. So a call to your cardiologist to let them know that you've had this event is really a good idea. You've highlighted already that, gosh, if that pain doesn't go away, then we need to get to the hospital to get sorted out, to get that ECG, to get that troponin, to get a visit to a cath lab is necessary, but otherwise highlight it with your cardiologist. For some people, if this becomes your usual pattern, and there are some people for whom that, there might be a stable pattern of chest discomfort that comes on, when you're getting up to that certain hill and you're trying to go up there at a slope in hot weather. And if that happens just on that hill, then that can be okay. And if that's a stable pattern that you and your cardiologist are used to, then you may not need to give them a call, because that's your usual pattern. And if you use your spray once a month, then that can be quite fine. So long answer to your question. If this is new and out of character, let your cardiologist know. Okay, so the second item is a comment from an individual who says that he had a non-ST elevation MI, meaning that it did not show up on the electrocardiogram when first going in, but the blood test did show that there was a heart attack, and there was actually a full blockage in one of the arteries, in the circumflex artery. So the question is, what is a non-ST elevation MI, and why would that not show up on the first ECG? So that's a great question. And if you look at the word non-ST elevation, that sort of tells us descriptively what the electrocardiogram looks like. The one we showed you during this session was an example of the ST elevation MI, meaning that the segments go way up, indicating that there's a heart attack going on right now. If the ST segments don't go up, it means it's a non-ST elevation MI, meaning that the electrocardiogram doesn't change. Sometimes the ST segments may actually fall downward a little bit or stay the same. It says that the electrocardiogram is not a perfect tool. It may also tell us that, that the thing that happened in the heart, the blockage that happened in the heart, might have happened some time ago. Like we were talking with the troponins, if they are high already when you get to the hospital, it means that your heart has already been damaged for several hours or even days. So the electrocardiogram might have been abnormal if we had taken it several hours or a few days before. So it was like it happened in the past. We don't have instant replay. What we have now is evidence from the blood test that there has been some heart damage done. And then when you've moved ahead and had the angiogram, they've actually discovered, well, it's been blocked off completely. And the likelihood is that blockage has been there for several hours or days already. Fortunately, they were able to open it up and put the stents in, so that's terrific. So non-ST elevation MI means that either we missed the original event or that there was an incomplete blockage. But in your case, it's likely that the time when the ECG would have been abnormal was occurring at some point in the past. Okay, the third question here that we have is a question about aspirin. And we talked about, and the specific question, how many aspirin should you take if you have a suspected heart attack? And so for many of us, we already take a baby aspirin a day. And when I ever ask the question, usually people tell me that they take an 81 milligram aspirin as the most common dose. If you're having new chest pain today, like our first questioner asked, then there's a likelihood that your the ambulance attendants might give you 2 additional aspirins to chew up and break them up into fine little bits and get them into your system. And 2 aspirin will be enough to knock out the platelets so that they don't try to attach to that thrombus that's trying to form in your arteries. Next question is about how blood vessels, can blood vessels grow bypass blood vessels? Yes, and this notion of growing collateral vessels. So in one of the first cartoons we showed you is that not only are these major blood vessels on the right side and the left anterior and the circumflex, but there's this whole tributary of smaller blood vessels that can form. And what our cardiology friends will tell us that in situations where there's been blockages that have happened, then there may be new vessels that will grow around the side or connections that can grow around those blockages, much like we might create new roads around accidents, or if a river gets blocked, then you might develop a new creek that goes around side of it. So these are collateral blood vessels, and these can grow. And we love this concept because we think that one of the ways of encouraging collateral blood vessels to grow is to stress out the heart system a little bit in a controlled way to encourage blood vessels to grow. So that's one of the byproducts that we do see with regular exercise programs to encourage these new blood vessels to grow. There, of course, also is a line of research that goes along this pathway as well, of actually injecting substances around the heart called vascular endothelial growth factors. And the idea is that if you give some of these growth factors like miracle grow for the heart, that you might actually cause some new blood vessels to grow. This is not prime time yet, but it has been an area of research for the last number of years, and hopefully will come to us in the future of just how do you get the right amount of this growth factor to the exact right area to cause blood vessels to grow in the right fashion. So we love that concept. We can do it safely with exercise in the safe and effective manners that you do, and there may be some other ways of encouraging some of these blood vessels to grow as well. Okay, is there anything else anybody wants to ask? If you put it into the Q&A, I can have a look there. I'm giving you 10 seconds. Okay, if not, I'm grateful to you for joining us today for this session. I will, as always, allude to the next things coming up. And tomorrow's session at 1 p.m. has become this famous and wildly popular Walk and Talk with Rob, and he'll continue to do these sessions for the near future. So tomorrow, 1 o'clock, join in for the Walk and Talk with Rob and do a little bit of your workout together. And then also tomorrow morning is the next in our Women with Heart Online series. This one is about mindful eating practices, and this will be facilitated by our two of our 3 outstanding registered dietitians. Fatima Ajwani and Veronica Rouse will be leading this session. So please join us for the Women with Heart Online series tomorrow morning. I thank you all for joining us today for this session. I wish you a heart-healthy day and look forward to connecting with you in the near future. Take care.